this lesson, we'll learn about Graves ophthalmopathy. Introduction. The most common cause of outletter or bilateral ptosis in adults or children is Graves' disease. The terminology used to describe ocular involvement in thyroid disease is often confusing. Graves ophthalmopathy, we also called dithyroid ophthalmopathy and dysthyroid eye disease, are interchangeable terms. Some degree of ophthalmopathy, usually mild, occurs in a high percentage of hyperthyroid patients. Severe infiltrative orbital myopathy with significant ptosis and restricted motility occurs in about 5% of cases of Graves' disease. This severe form, however, can also occur with hyperthyroidism or with no detectable thyroid abnormality, in which case the term ophthalmopathy Graves' disease may be used. Thyroid ophthalmopathy is thought to be autoimmune disease. It's often seen in autoimmune thyroiditis. Antithyroidable, antimyopsol, and other antibodies can usually be demonstrated, but their role in pathogens is in question. Autoimmune thyroid disease is associated with myasthenia gravis. Clinical findings, including superior limbic keratoconjunctivitis, ptosis, lid retraction, lagophilocyma, diploma, ocular motility distribution, corneal exposure, and so on. Ocular surface discomfort is very common in all stages of the disease, in some cases due to superior limbic keratoconjunctivitis. Ptosis associated with thyroid disease is accompanied by lid retraction, which serves to distinguish it from other cases of ptosis. Lagophilomas results from ptosis and lid retraction, and corneal exposure may be a factor even in mild cases. Ptosis is association with thyroid ophthalmopathy is usually due to axons myasthenia gravis, which may also contribute to ocular motility disturbance. The extraocular muscle involvement of thyroid ophthalmopathy begins with lymphatic infiltration and edema of the retract muscles. In time, the inflamed muscles may become fibrotic and permanently restrict. Diplopia usually begins in the upper field of Graves. All the extraocular muscles may eventually be involved, and there may be no position of Graves free of diplopia. Throwing of the inferior retract, which are predomestic involved, results in evaluation of intraocular pressure on upstay, or in severe cases, even on looking straight ahead. From the CT and MRI, we can see the swollen extraocular muscles. If the extraocular muscles become massively enlarged, there may be compression of the optic nerve at the orbital apex, not necessarily accompanied by significant ptosis. Early signs include an affected pupillary defect, impairment of color vision, and slight loss of visual acuity. Blindness is liable to occur if compression is unrelieved. Treatment. An important goal of treatment is to avoid exposure keratitis. As the disease progresses, it may become necessary to address the problems of diploma, ptosis, and compressive optic neuropathy. Management of severe cases is difficult and multi-described. An endocrinologist should manage the thyroid status. optimal control being so crucial to minimizing the orbital disease. Radioiodine therapy and cigarette smoking are important risk factors for development of ophthalmopathy. Cornea exposure and ocular surface discomfort are usually managed with topical lubricants. Compressive optic neuropathy and ptosis with severe exposure keratitis, uncontrolled by lubricants, require emergency treatment, initially with high-dose systematic steroids. If this is inadequate, either acutely or in long term, including due to steroid complications, surgical decompression of the orbit is usually performed. Several techniques have been devised using external or transnasal endoscopy approaches. All aim to expand the orbital volume by removal of the bony walls, usually the orbital floor, middle wall, and possibly lateral wall with incision of the orbital presosum. There is a risk of causing or exacerbating diploma and a lesser risk of orbital infection. Orbital radiotherapy may be an effective alternative in patients unsuitable for surgical with less severe active disease, but should be avoided in diabetics. Exposure keratitis due to severe ptosis may respond to lateral transraphy. Eyelid retraction is often more disturbing than ptosis, both functionally and cosmetically. Surgical orbital dermodepressation may improve lid retraction, but correction of the retraction by lid surgery is safer and camouflages ptosis to some extent. The upper and lower lid retractions can be lengthened by insertion of spares such as eye blank sclera. Small amounts of lid retraction can be corrected by decelerating the retraction from the upper tragus bladder. Once the ophthalmology is inactive, surgical orbital decompression can be performed for cosmetically unacceptable ptosis, but the risks of surgery need to be borne in mind. Double vision may not be sufficiently, both there are some to require treatment. While the ophthalmopathy is active, primes or occlusion may be helpful. Thrombus surgery should not be undertaken until the ophthalmopathy is inactive and the ocular motility disturbance has been stable for at least 6 months. Tight muscles, usually inferior and medial retract, are recessed using the adjustable structure technique. Most patients can achieve at least a small area of bioocular single vision in a useful position of grace. Torsional diploma, the result of oblique muscle involvement, complicates management. Some patients have intracapital diploma despite all attempts at correction. Okay, that's all for today's lesson. Thank you.